Okay, good evening, everyone. I'm Tom Flynn, the chair of Sunnybrook's Board of Directors, and it's my real pleasure to be here with you this evening to welcome you to our virtual speaking series. Every April, we turn our focus to cancer. And as the Canadian Cancer Society notes, cancer isn't just one disease, it's more than 100 diseases. This evening, our panel of real experts will provide the latest information on radiation and lung cancer, interventional pulmonology, and new surgical approaches for lung malignancies. As the Canadian Cancer Society cites, lung cancer is a common form of cancer in Canada. The majority of cases occur in those aged 50 and older, and all of us here in Canada had a reminder of that, unfortunately, with Guy Lafleur's recent passing. 1 in 14 men and 1 in 15 women will be diagnosed in their lifetime. Pretty amazing statistics. There's a lot to discuss in terms of what is happening around the understanding and treatment for affected patients. Alongside our esteemed panel of presenters, we are very fortunate to have Dr. Calvin Law moderating tonight's discussion. Dr. Law is the chief of Sunnybrook's Odette Cancer Centre and regional vice president of Cancer Care Ontario. He is also a cancer surgeon specializing in pancreatic and gastrointestinal surgical oncology. Dr. Law has authored over 180 peer-reviewed publications and won numerous teaching awards. And that is obviously just a very short snapshot of his bio. Now, as board chair of Sunnybrook, I do have the privilege of hearing a number of Sunnybrook's leaders presenting over time. And I can assure you that none is more passionate about their subject matter, more knowledgeable about it, and more energizing and engaging as a speaker than Dr. Law. And so you are in excellent hands with him here tonight. And Dr. Law, with that, the floor is yours.
Thanks so much, Tom. Tonight, the focus should be on this amazing team that we have lined up for you. And again, good evening to all of you. It's a wonderful time. We love spring and we love this opportunity to get together with our community as we do every spring to talk about some really interesting topics in our cancer work and the care that we provide our patients. So tonight, our lecture series tonight is called Just Breathe. Great for the spring. And we're very lucky this evening to have, like I said before, an absolutely great lineup of speakers for you. I'll give you a quick overview and I'll give you a little bit more about them as we go through. But we'll start with Dr. Alexander Louis, who's going to kick off the talks with his presentation on radiation and its application to lung cancer, common misconceptions clarified. Then we're going to go to Dr. Harvey Wong, who will talk about interventional pulmonology, some new and minimally invasive approaches to thoracic oncology. And last but definitely not least, Dr. Nagar Ahmadi will tell us more about new surgical approaches in the treatment of lung malignancies. So despite all that, as we always do, we're definitely going to have some time at the end of this evening for you to ask some questions for our panel, and we'll do our very best to get to as many questions as we can. I want to thank everyone in advance who has already submitted a question online. Please feel free to send your questions while these presentations are going on, and do it at the same time, and our team will be helping to sort these out. And again, we'll do everything we can to answer as many of your questions as we get. We may not be able to get to every question, but we'll try to cluster some thematically together, and we'll try to do our very best, like I said, to get through all of it tonight. So on that note, and as exciting as it is, I'd like to begin the evening by introducing our first speaker, Dr. Alex Louis. Dr. Alex Louis is one of our radiation oncologists who's doing a lot of outstanding new work in applying radiation therapy to lung cancers. But I think what's important for you to know is Dr. Louis is also our esteemed lead for the entire multidisciplinary site group for lung cancer here at the Odette Cancer Center. So he leads our team, and I can't think of a better person to lead off with his talk, Radiation and Lung Cancer, Misconceptions Clarified. So on that note, Alex, over to you.
Thank you, Dr. Law, for the introduction, and thank you everyone for joining us today to hear more about lung cancer. I'd like to start off with just a very, very general background and overview. the first question that I often get when I tell people that I'm an oncologist, just say outside of the hospital, is, well, what is cancer? Cancer comes from the Greek word carcinos. And back in 460 to 370, thereabouts BC, Hippocrates was an ancient Greek physician and noted that in the context of this growth that was cut from what is now known as a malignant tumor, that from the side view, the veins that were growing from the cut surface actually kind of looked like a crab. And so carcinos, or crab, was later then from sort of the Latin perspective, given that particular name. And for that reason, we now know in common vernacular the word cancer. Well, what is cancer? Cancer clearly is a big problem from a public health point of view. It is actually the #1 cause of premature mortality. And we're looking at Canada in particular. These are statistics from the Canadian Cancer Society, 2017. Over 200,000 Canadians were diagnosed with cancer in 2017. And importantly, 1 in 2 Canadians will actually develop some form of cancer, whether incurable or curable, in their lifetime. In 2017, over 80,000 Canadians actually passed away from cancer. And 1 in 4 Canadians, unfortunately, will pass from their cancer diagnosis. Now, despite some of those sobering statistics and thoughts to the contrary, there actually has been a significant reduction in cancer mortality over the last 3 decades. And the reasons for that are manyfold. It's partially related to improved screening or increased detection or better ways for technology for us to identify cancer, not only in advanced stages, but more often in earlier stages. We also have better treatments, whether it be surgery, whether it be newer forms of radiation technology, or even medications that build on the traditional chemotherapy of how we can manage cancer, and importantly, when we give these treatments, better ways where we can support individuals to get through their treatments and some of the side effects that may occur. So again, lifetime risk of developing cancer, about 1 in 2, a little bit higher for males as compared to females in Canada. And again, lifetime risk of passing from cancer, about 1 in 4. The most common cancers, if we're looking at from a gender perspective, it isn't lung cancer. For men, it's prostate cancer, and for women, it's breast cancer. But lung certainly is very common in both genders. And even though it is not the leading most common type of cancer, it certainly is the leading contributor for cancer-related death, both in Canada as well as worldwide. So if we look at advocacy, grassroots programs, as well as community support of cancer, any type of cancer, there are different types of ribbons. And these ribbons are all important for different types of cancer. And perhaps what most well known is the pink ribbon for breast cancer. That's probably how things all started off. And each cancer has their sort of banner ribbon. And what's notable about lung cancer, and I learned when I was a medical trainee, was that it's the white ribbon, or in some areas, actually a clear ribbon that represents lung cancer. And the reason for that is, as a clear ribbon, or the white ribbon, it was felt when that color was chosen, or the absence of color rather, is that lung cancer can sometimes be overlooked, both from a public health perspective, from a fundraising perspective, an advocacy perspective. And I would submit that historically, it's somewhat because of the stigma of lung cancer. By nature of the common association of cigarette smoking, it is felt that the behavioral choice of smoking perhaps is the causative reason of lung cancer, and for that reason, perhaps it does not deserve the same level of attention as other malignancies. Well, this is the White Ribbon Project. It's a very well-known initiative worldwide. And their motto is, it's time to change the lung cancer story. And what the White Ribbon Project does is that to promote awareness of lung cancer by changing the public perception of the disease. in that not just for smokers, but anyone with lungs can develop lung cancer. Some more hard facts about lung cancer, and this is from Lung Cancer Canada, and it's a fantastic website, lungcancercanada.ca, for a wealth of resources for both patients as well as caregivers alike. As I had mentioned, lung cancer is the most commonly diagnosed leading killer of cancer in Canada as well as worldwide. It accounts for 1 in 4 cancer-related deaths in Canada, as well as a number of other interesting tidbits as summarized in this particular poster. So I'd like to take the opportunity to try to distinguish between what are some myths of lung cancer and what are, in fact, real facts of lung cancer. So the first myth we kind of alluded to, and that is only smokers can get lung cancer. Well, the fact is that yes, tobacco is the leading reason that individuals may develop lung cancer, and about 3/4 or 3/4 of cases in Canada are associated with tobacco use. Lung cancer can happen in never smokers, and that's probably in about 15% in North America. In other parts of the world, like Asia, it's actually about 25%. And for individuals who have lung cancer and are never smokers, they actually more commonly present in an advanced stage where the malignancy may be potentially incurable. Well, here's another myth. I already have lung cancer, so what's the point in quitting smoking? Well, here are the facts. There's a lot of benefits of quitting smoking. Number 1, if you quit smoking and your treatment team recommends surgery, quitting smoking can result in fewer complications after surgery. Another fact, quitting smoking also reduces the risk of developing the lung cancer from coming back or developing a second smoking-related cancer in the future. Another benefit, quitting smoking in general can help to improve breathing. Another myth, a diagnosis of lung cancer is a death sentence. And this isn't just a myth of lung cancer specifically. Again, anytime you hear the C word, very commonly individuals and patients fear the worst, which is quite natural. The fact of the matter, as I mentioned, lung cancer still remains a leading cause of cancer-related death in Canada, but there have been significant advances, even in the last 5 or so years, across all diagnostic as well as treatment disciplines, looking to work together to fight this disease, whether with the respirologist like Dr. Wong, pathologists, our team here is led by Dr. David Wang, medical oncologists, also known as individuals who prescribe medications for cancer, radiation oncologists like myself, and surgeons, thoracic surgeons like Dr. Ahmadi. Well, back when I was a medical resident, and this is 10 or so years ago, it was quite sort of straightforward when we had to prepare for our board exams that there is really only 2 types of lung cancer that you had to sort out. Is it a small cell lung cancer? And us physicians, we're not particularly creative. If it's not small cell, then it's non-small cell. Well, there really has been significant advances, again, in the last 10 years on how we categorize lung cancer. And that goes hand in hand with what types of medications that we have available to us, building on the traditional chemotherapy. So chemotherapy, in very broad strokes, almost acts like a poison for lung cancer. But by nature of acting like a poison for lung cancer, that's where it can also cause side effects to the body as well. Well, one major advance in the lung cancer field is this newer type of treatment known as targeted therapy. Targeted therapy uses medications or drugs to target specific abnormalities or mutations within the lung cancer. So if you have a biopsy that's done by someone like Dr. Ahmadi or Dr. Wong, this is sent for sophisticated testing, much like if you're getting a COVID swab and you're doing what's known as a PCR to identify what subtype or variant of lung cancer this may be through a number of lab tests. And if you identify that there's a particular target or signature within the lung cancer, then there may be a medication designed to particularly focus on that. Similarly, another sort of broad advance in lung cancer has been the use of another type of medication known as immunotherapy. Well, immunotherapy, it acts as a medication in a somewhat opposite way of chemotherapy. As I mentioned, chemotherapy almost acts like a poison, whereas in immunotherapy, it uses your body's own defense mechanism, your body's own immune system, to better detect the cancer, using your body's own defense mechanism and machinery to try to fight the cancer. And oftentimes, these two classes of medications are associated with fewer side effects and potentially better outcomes than the traditional chemotherapy. Here is a very updated slide for our medical residents who are now studying for their exams, not like the simple pie chart that I had to study 10 or so years ago. And this is only a schematic representative of one of the types of lung cancer, adenocarcinoma, where there are now many different subtypes of mutations that have been discovered, and importantly, going hand in hand with medications that can target those abnormalities, many of which are funded through our Canadian healthcare system. So just to take a step back, this is a fantastic book, The Emperor of All Maladies, Biography of Cancer and Cancer Treatment. If we look at lung cancer treatment, going back to the end of the 1800s, that's when radiation therapy was discovered. Lung cancer surgery, the first case described in the 1930s, chemotherapy in the 1940s, and then a number of advances from a technology point of view for radiation, and these newer medications, the targeted therapy, immunotherapies, as well as more minimally invasive approaches on how we can do procedures such as diagnostics as well as surgery, which we'll be hearing more about later today. So what about what I do, which is radiation? So radiation we use in low doses to detect cancers through X-rays and CAT scans. But when we're using as high doses, that can actually be used to damage a cancer, to almost, as it were, fry up a tumor and to leave a scar. So one exciting advance over the last 10 or 15 years is a special form of radiation known as stereotactic radiotherapy. One of the first cases of lung cancer in Canada was treated right here at Sunnybrook. And this is looked at as an alternative to surgery, where sometimes individuals may not be well enough to have a surgery for an early stage 1 lung cancer. Well, we also use radiotherapy in the other stages of lung cancer, stage 2 and 3, what we call locally advanced, either combined with chemotherapy or on their own, still with an opportunity for cure and what we call primary management. We can also use radiation as what we call post-operative treatment. So someone like Dr. Ahmadi removes a tumor. If there is significant concern that there might be some microscopic disease or cancer that's left in the surgical bed, then radiation or even chemotherapy can be used as an insurance policy to try to eradicate or cure, eliminate any cancer cells that may not be detectable by a scan, but may be hiding and left behind. We can also use radiation or even surgery when we are faced with a recurrent situation, i.e. if a second cancer of the same type shows up, so this may be an opportunity for a second chance for cure. We also use radiation in scenarios where the cancer is advanced and often incurable, what we call metastases or stage 4. In situations where we have stage 4 lung cancer and there are not symptoms, and perhaps the cancer is only in a couple of different places within the body, we can incur a more aggressive approach of using surgery and stereotactic radiotherapy to try to eradicate the cancer that we see. And we can also use radiation to try to improve symptoms from lung cancer, such as pain. Sometimes lung cancers have a propensity to bleed, or if they incur difficulties in breathing by nature of taking up real estate in the lung. This is a general schematic of what we do here in the radiation department. We use fancy technology to measure the lung cancer as an individual breathes in and out, it may move a little bit, and we can track that. And then we use linear accelerators, the newest type of technology, to aim radiation to try to damage the cancer and ideally eradicate or cure it. We have the ability of tracking when cancers breathe and move up and down with breathing motion. And we are able to target such types of tumors within very high accuracy and precision, often within a millimeter or two, to ensure that we're in the right place, which was challenging to do a decade ago. And the newest forms of radiotherapy are available here at Sunnybrook: stereotactic radiation and IMRT, or what's known as intensity modulated radiotherapy, that is used in more advanced cases. I'd like to end off by just highlighting some of the initiatives that we've led here with our lung cancer team. And one is, I mentioned stereotactic radiotherapy, or SBRT, also known as SABR. This is typically given over a few visits, 4 or 5 visits to the cancer center. And there has been some suggestion, primarily from one of the US-led groups, that with today's technology, we can actually get everything done in one go. And this is a review that's been led by one of our medical residents, that was brought about by the COVID-19 viral pandemic by trying to limit the number of visits to the cancer center, that we have now implemented using this type of modern technology to give treatment in some scenarios of early lung cancer or stage 4, i.e. metastatic lung cancer, all within one treatment visit, to try to put less burden on the cancer system, as well as less burden on the patient, as well as their caregivers as it relates to outpatient visits. A second development, this is a clinical trial that our team led with a number of different centers across Canada, wherein we prove that using the newest form of radiation technology can still achieve the same goals in advanced lung cancer of improving symptoms, whether it be shortness of breath, bleeding, or other types of problems from the lung cancer, but at the same time, reduce the side effects from the radiation treatment itself. And one common side effect when you are using radiation in advanced stages of lung cancer is the collateral radiation to the esophagus, or the swallowing passage, which can cause heartburn or even interfere with nutrition. And this was a study, again, led by our group, that suggested that using the latest technology may help with side effects from treatment. As a final point, I'd like to highlight 2 of my favorite books. The first is entitled When Breath Becomes Air. This was written by Dr. Paul Kalanithi. Dr. Kalanithi was a surgeon that was training at Stanford when he was diagnosed with advanced lung cancer. Unfortunately, he has since passed. But when he was diagnosed with this end-stage cancer, he wrote quite beautifully the perspective of being both a physician, knowing all the aspects of what to expect, but at the same time grappling with that sort of professional, personal interface, and also the birth of his daughter prior to his passing. And secondly, Taking Charge of Cancer. This is a book by my mentor, Dr. David Palma, that's written particularly for patients as well as their families on how to best understand cancer, its journey, and its diagnosis in the lens of the Canadian healthcare system and navigating through it. So with that, I'd like to thank you for your attention. And again, I'm sure that we'll have a lot of opportunity to address any questions that audience members may have.
Thank you so much, Alex. I really appreciate it. And I can't thank your team enough for the many patients where it's almost like magic what your team does with this. I'll guess I'll use my favorite acronym, which is SABR, just because it sounds cool. But incredible that somebody, when I was a medical student with a lung malignancy, you'd think about all the treatments they need, and now not without even a scar, it's been treated. So thank you so much. I'd like to now move to our next presenter, a respirologist, Dr. Harvey Wong. Harvey is somebody I treasure so much. He's a respirologist, but has come to our cancer center with such a strong passion and belief in helping our patients. And he is the founder of two of our important clinics called Epic and Trap that has helped the symptoms, relieve the symptoms of many of our patients. And so Harvey is such an integral member of our team, and I'm so pleased he was able to share some of his time tonight. So Dr. Wong is here to talk about interventional pulmonology, new and minimally invasive approaches to thoracic oncology. And again, Harvey, thank you so much for being with us tonight. Over to you.
Thank you for that lovely introduction, Dr. Long. So I will be talking about interventional pulmonology, new and minimally invasive approaches to thoracic oncology. I do have a couple conflicts of interest I just wanted to kind of disclose. I do have a couple relationship with some medical device companies that help fund some of my educational initiatives, such as the simulation sessions I run for our respirology residents, as well as our training program. So here are my learning objectives for my talk. I wanted to briefly describe the field of interventional pulmonology. I wanted to compare some of the 21st century tools that are now used for the diagnosis of lung cancer and help you recognize the importance of high-functioning multidisciplinary teams and programs in the diagnosis and treatment of thoracic malignancies. So just to start off, what is interventional pulmonology? I don't think that I can do justice in 15, 20 minutes to explain what an entire field is, but I thought that I would give you some of the highlights. Basically, interventional pulmonology is for medical doctors such as myself, a lung doctor, respirologist who just likes playing with toys. That's essentially what it is. We use minimally invasive tools to help diagnose and treat lung conditions, and a lot of these tools are used in the realm of thoracic oncology. This little toy here is called a bronchoscope, which is a very thin camera that is used to access the lung through the mouth. And I'll be talking a little bit more about that in the next few slides. So just to give you a few highlights in terms of the things that I do. One of the things that I deal with are airway disease, and in particular, airway obstruction. So in this picture here, you can see someone who's actually had a narrowing of a small airway here. This is what a normal caliber of an airway would look like. And you can imagine that if you have a pinhole of a hole here, not a lot of air gets through this little hole. And so people can be quite short of breath. In this case, this is someone who had radiation treatment for a previous cancer and had some scarred down tissue, and because of that has had narrowing. And some of the things that I can do, for example, would be to go down with a camera and inflate a balloon that is stiff to dilate that airway, so that afterwards you can see that you open up the airway and patients become less short of breath. Another thing that I can do is to help remove some tumor from the airways. This is an example of a tumor here that's in the right side of the lung. In this particular case, this is using a cryoprobe. So it's a probe that can become very cold very, very quickly. And I like to describe this akin to, remember when you were young and it was the summertime and you really wanted that popsicle and you weren't thinking it's hot, your tongue is moist, and you put that popsicle on your tongue and oh no, it gets stuck and you can't get it off. I don't know if that's happened to any of you before, but this is the idea. You do this flash freezing and it sticks, this probe sticks onto this tumor and you can actually pull and remove tumor that way. It's kind of interesting to kind of describe some of these procedures that I do, but I thought that in preparation for this talk, I actually prepared a few videos. I'm going to try to see if I can share a video to see if this works. This is actually a patient that I share with Dr. Louis, actually, with a central tumor. Let me see if this works. Hopefully people can see this. This is an example of bronchoscope that I talked about reaching the lungs through the mouth. This is a CT scan of a patient in which you can see that there's a narrowing here where the arrow is. Now, if you follow this arrow, this is a central airway that's open. And if you follow to the left, you can see that it's very small and it's there's tumor that's there. So I could put my fancy camera into the lungs. This is what it looks like, the tumor looks like from inside the lungs. This is using a laser to cut and burn out the tumor. I can use fancy forceps, these graspers, to remove the dead tissue. And then here you can see the before and after effect. You can see afterwards, you can see that the airway has regained patency. So that's one of the examples of a procedure that I can do. Another thing that I do is I work with what's called the pleural space. So the pleural space is a space that is between the lung and the chest wall. And that space can sometimes be filled with fluid in certain disease states. In the case of cancer, which is actually a very common cause of fluid buildup in this space, cancer can spread to the lining of lung and cause inflammation to happen. And because of the inflammation, fluid gets built up. The cancer also blocks some of the drainage sites where the fluid normally gets resorbed, and you get this buildup of fluid pushing on the diaphragm, pushing on the lungs, so people get quite short of breath. So patients can come to the hospital and we can do these drainages to drain the fluid up so that we can re-expand the lungs so patients become less short of breath. But what if someone's fluid keeps coming back so quickly that they really don't get a chance to come back to the hospital, or maybe they're just too weak and frail because of their cancer that they can't come back? So this is one of the things that I do too. I put in these semi-permanent tubes, these tunnel catheters that can stay into a patient, and then we can arrange home care nurses to come to patients' home so that they can drain this fluid from their home. So this is an example of an X-ray of someone who has a pleural effusion, or this fluid that's around the lungs. You can see that on the left side here, or rather your right, this is the left lung, but on your right side, you can see that the lung is nice and aerated. It's quite large. In this case here, because of the fluid, which is represented white here, the lung is quite small. This is an example of a tube that's been inserted. And you can attach the tube to a drainage bottle, and with the bottle draining the fluid, you can see that the lung has re-expanded. So I'm going to spend a little bit of time talking about diagnostics specifically as it pertains to interventional pulmonology and cancer. I'll be talking a little bit about endobronchial ultrasound, navigation, and a little bit about the newest kid on the block, robotic bronchoscopy. So here's some of the general principles that we adhere to when we're talking about picking the best tool to diagnose cancer. You obviously want to find a tool that is most economical, and that's especially important in a single payer system like OHIP in Ontario. You also want to have a tool that will give you the most result as possible. So you want the tool to be accurate, and you want to get enough tissue to be able to ensure that you get a diagnosis. But in this day and age, as Dr. Liu had already explained to you, we know that there are many different mutations that are on tumor cells. You want to make sure that you can get these additional tests done on the tumor cells to figure out what kind of target therapy a patient might be amenable to being treated with. The other thing you want to ensure is that the tools that you pick is as least invasive as possible. You do not want to be causing harm, and you want minimal complications. So what tool we use for diagnosing cancer really depends on the location of where the cancer is found. So what if you have a very central lesion or a tumor that is very close to the central airways? So the gold standard before in the past was what we call mediastinoscopy. The procedure entails making a small incision in the neck area and going in with a camera just close to the airways here to remove any tissue or lymph node that might contain cancer. This is actually already quite a very minimally invasive procedure that is usually done on the same day. It is quite accurate in that it can find cancer in 80 to 90% of the time when there is cancer present. And the complication rate is actually quite low. It's 2.3%. But it does entail having to have an incision made and a little bit of recovery and some pain involved with this procedure. So the latest way of diagnosing these central lesions is by something called linear endobronchial ultrasound. And it is using one of those bronchoscopes that I was talking to you about, but at the end of this bronchoscope is this small ultrasound that is found at its tip. So using the ultrasound, you can actually locate lymph nodes or cancer masses that are near the central airway. And in real time, you can actually sample them using a needle. You can avoid structures that you don't want to puncture, such as blood vessels, because this is done under direct visualization. You're doing this by looking with an ultrasound. Again, this is a very accurate test. You can find cancer in 80 to 90% of the time. Because you're not making any incisions, there's actually no pain involved. Your lung actually does not have any pain fibers. So this procedure is actually painless. The complication rate is actually very low. It's 0.15%. Going to try to show you an example of a procedure. Here we go. So again, this is the camera that I talked about. It's this thin, long camera here. The camera tip has a video camera, very small here. It also has the ultrasound here. It also has the hole where the needle comes out of, so we can sample our lesion. We can inflate a balloon so that we can visualize the tumor a little bit better. This is an example of a CT scan of a patient with a central tumor here. We're going down again with the camera. And you see here, inflating the balloon on the right side is the white light view. We're going to put the camera close to the airway, and you can see the tumor here on the ultrasound view now. I'm going to now puncture it with a needle, and you can see the needle go in. I'm going to add a suction syringe, so this sucks up. It has negative pressure, so it sucks up material from the needle. And then the needle cuts into the tumor like this, so that we can sample the tumor. And then we expel the material from the needle into a preservative. Just going to go back to my slides here. All right. So what if though the tumor is actually too far out, it's too peripheral, it's not near a central airway, meaning I can't access it using that camera? Well, historically, the way that we used to, or we still do actually, sample these tumors that are more in the periphery, that are further away in the lung, is by what's called a CT-guided biopsy. So a patient will enter a CT scanner such as this one here, and while the CT scan is being performed, an interventional radiologist can slowly advance a needle into the tumor like you have here in this picture here. Now, this is a very accurate test. Again, it can find tumor in over 90% of the time when cancer is present, but it does have a higher complication rate because the lung is like a balloon. It is full of air. And if you're puncturing it with a needle, you can cause air to leak out of this small hole that you've now created, and you can cause a lung to collapse. So this is a patient of mine actually that had this complication just a couple months ago. And you can see here, or maybe you can't, I've shown an arrow here to show that the lung has actually dropped. The lung actually stops here. The lung has actually collapsed. This is actually air that has leaked out, causing a patient to be short of breath because the lung is smaller now. And in order to fix this problem, you have to put a temporary tube in here to re-expand the lung. There's also the risk of hemorrhage or bleeding because you are sticking a needle, and you have to traverse quite a bit of normal lung in order to reach this, this tumor. So this is another newer way of sampling these peripheral or further away tumors. And it's by using a different kind of ultrasound called radioprobe endobronchial ultrasound. So it looks like this as it's expelled out of a camera. And the idea is that you find this tumor and you leave a sheath in place, which is like a little pathway once you've located the tumor, and then you can use different instruments such as a forceps or a needle here to sample the tumor. So this is a depiction here where you can see this camera can't quite reach this tumor here. So you have to use these other instruments to guide you to try to find this tumor. But how do you locate this tumor? Well, there's new software out there called navigation. And the way that you use this data is you do a CT scan, and you're able to do a virtual bronchoscopy. So you're able to, using a computer-generated system, be able to highlight what the airways look like on the inside and create a roadmap for you to get to that tumor. A fancier way of doing that is actually using electromagnetic technology. So you have an electromagnetic board that a patient lies on top of, and using technology that is akin to GPS, you can actually track your instruments as they're in the airway and track it until it reaches the tumor. I also have a video here to show how that is done. See if I can find that video. Okay. Oh, this is not the right one. I'm very sorry about that. Let me try that again. Here it is. Okay. Again, I'm using a thin camera to locate this tumor. Here's an example of that small ultrasound that I was talking to you about. You can fit it through the working channel, see it stick out of the working channel. This is a normal view of what the radioprobe looks like. It's a smooth sort of appearance. When it's within a tumor, it will look very different. You can find cancer like this on the ultrasound. Here's an example of a patient who has a small tumor here. It's highlighted also on the CT scan and PET scan. Using a CT scan image, you can see the tumor here. As I'm scrolling, you will be able to see how we can track the airways as it goes to the central airways. Now you know which airway to lead into the nodule. This is one of our fellows doing this procedure with the camera. We navigate the camera into the airway that leads to the nodule. And then we put our tiny ultrasound through the working channel. We bring our X-ray machine close to the patient. And then we locate the nodule. See, right here, you can see it on the ultrasound view here. Correlates to the X-ray view here. Now we've confirmed the airway that leads to the nodule, and we know how far to extend our instruments to reach it. We can send in different types of instruments to sample the target lesion. In this case, a needle is being deployed into the nodule. We put the same suction syringe to suck the material into the needle. And we expel the material into a preservative. Similar procedure could be done using these tiny forceps. You can see it on the X-ray view there. So that's an example of radioprobe endobronchial ultrasound. And this is actually quite an accurate test as well. It has a sensitivity or accuracy rate of 72%. And the complication rate is a lot lower than doing the CT guided biopsy, because rather than puncturing the balloon from the outside and traversing lots of normal lung tissue to get to the nodule, we're actually going from the inside. So we're not actually creating a hole in the balloon, and we're able to sample. So the risk of complications is a lot lower. So this is the newest kit on the block. It's called Robotic Bronchoscopy. It's not even available in Canada yet, but it's being actively investigated in the US right now. And it is, as it sounds, it's using a small robot to try to get to these lesions. And you can see here a remote control. The operator uses a remote control to more specifically get to the nodule. And the reason why this can get further than our regular cameras is that this particular camera is like a telescope. So once it reaches resistance, there's actually an inner smaller camera inside that comes out. And once it reaches resistance into a smaller airway, another small camera comes out. And in so doing, you can actually reach into the really small peripheries of the lung and sample. So it's still actually being investigated. It's a little bit more accurate than using the radioprobe and navigation method, 82%, but they're still working out the kinks. The complication rate is a little bit higher, and the bleeding rate is also a little bit higher. So that's my little spiel about how we diagnose and get tissue for diagnosing cancer. I wanted to spend a few minutes just talking and highlighting some of the programs that we run at Sunnybrook Hospital to help in managing and diagnosing cancer, because it's all fine to talk about the tools that are available. How do you operationalize this? So one of the programs that we run is called the Lung Diagnostic Assessment Program, or Ldap. Another one I'd like to highlight is called the Effusions Procedural Interprofessional Clinic, or EPIC Clinic. And both of these programs do an excellent job keeping patients out of the hospital and expediting care. So Lung Diagnostic Assessment Program is our clinic that helps expedite the workup of patients who have suspicious findings on chest imaging for lung cancer, such as this chest x-ray here that shows this small nodule suspicious for cancer. So this program is run by physicians, and it's usually triaged by a respirologist, such as myself. And depending on what the scenario is, we may right away get our thoracic surgeons involved. It's someone who's fit for surgery and should go for surgery and not delay, we may make that route. Or if it's something where more consideration is needed for diagnosis, then we might perform some tests first. And the idea is that because it's a physician who knows about cancer diagnosis and staging, we're appropriately going to be able to choose the appropriate test, the fastest test to get a diagnosis, rather than just referring to an oncologist and having delay, because an oncologist, a medical and radiation oncologist may not be someone who may make the diagnosis. They may not be the ones to perform the test or organize the test to sample these suspected cancers. We have administrative support and nursing as well to help us. And I just want to highlight successes in the Ldap program at Sunnybrook. So Cancer Care Ontario has a target of making sure that every program is able to diagnose a lung cancer from the time of referral to the time of diagnosis being less than 28 days. And you see, this is real data from Sunnybrook. We were not doing so well prior in early 2017. And part of the reason is because we had referrals, a lot of referrals. And before we had our advanced bronchoscopy program, most of our way of diagnosing cancers were using the older technology or relying predominantly on CT-guided biopsies, and the wait times for our biopsies were very long. When we started our program and we have these newer methods of diagnosing cancer, you can see that the time to make these diagnoses significantly improved, such that we were reaching our target 100% of the time by late 2018. This is despite the fact that our referral volumes have continued to increase in size. So we know that we're making a quicker diagnosis of cancer, which means that patients get treated with their cancer sooner. Because we have this program, patients aren't relying on being admitted to hospital to expedite the care, to expedite these investigations. We run all of this clinic and all of the procedures as an outpatient basis, meaning patients do not need to be admitted for any of these procedures. Now, the other program that I want to highlight is the EPIC Clinic. This is an outpatient clinic program where we perform bedside ultrasound guided procedures. Again, this is all done as an outpatient, meaning patients do not need to be admitted. They come into our clinic, and basically we're using ultrasounds to either treat patients or to diagnose patients. This is just an example of someone who has a pleural effusion or that fluid. And you can see that using the ultrasound here. So what do we do in this clinic? Well, this clinic has substantially expanded since its inception. We now run this clinic 3 times a week at the Odette Cancer Center. It's an interprofessional team with 3 physicians that have interventional training, such as myself. We have dedicated nurses and administrative support. And what we do is we provide 24/7 patient support in collaboration with home care and our other colleagues. The procedures that we do are pleural drainages, meaning, as I talked to you about in the earlier slides, of when you have fluid buildup in the pleural space, we can drain that fluid. We can insert these tunnel catheters, we can remove them. We can deal with any complications that arise if there's infections or bleeding, or if a catheter stops working. We also perform ultrasound guided biopsies of lymph nodes and superficial lung lesions and skin lesions. And again, like I said, we manage all complications related to the procedures. And just to highlight the success and how this works, this is the before EPIC Clinic state. This is just highlighting one aspect of our clinic, which is patients who have pleural effusion, patients who come in because their fluids build up around their lungs. They get very short of breath. Before there was this clinic that was there, these patients would either get admitted or they would see other doctors in other clinics. But the problem was that once they got admitted, because there wasn't any standardized path, basically they would have various kind of options in terms of different services of being called. There was no standard of care. And so, there was no standard in terms of algorithm, in terms of how these patients were managed. So there was a lot of delay and a lot of inefficiencies in the system. And a chart audit found that this whole pathway, on average, took about 15 days to sort out before a patient would be discharged. With the new state, with this new clinic that we now have in this program, the idea is if a patient comes in knowing that they have shortness of breath and an X-ray identifies that there is fluid around the lungs, a temporary drain can be done in the emergency department. Then they can be referred to our clinic where we manage everything. And with this program and this dedicated pathway, we've certainly found with further chart audits that our length of stay for these patients are significantly reduced. It really reduces emergency department visits, hospital admissions, as well as length of stay. With that, I just want to summarize that hopefully at this point, you've learned that patient care can be improved due to minimally invasive procedures in interventional pulmonology. We have new exciting diagnostic tools for lung cancer, aiming to become less invasive and more accurate. And in an integrated team approach, improves patient care for thoracic malignancies. I really can't do this alone, so this is just a quick slide with some acknowledgements of all the help that I've gotten. A lot of this equipment in these programs are very expensive, and I'm very thankful for Sunnybrook and the Odette Cancer Center, as well as the Sunnybrook Foundation, for helping to fund some of these.
Well, that's amazing, Harv. Thank you so much, and great summary, and reminds me that you are a maze master. I don't know how you guys find your way around. The lung is such a complicated place. Thank you again. Now we're moving on, and I just want to take this moment to remind everyone to, if you have any questions, please submit them now as we're starting to collate them. And as I move on, certainly not last, but certainly not least, our final speaker for the evening, Dr. Nagar Ahmadi. She's one of our thoracic surgeons, and we're so pleased and proud to have her on our team. We used to joke a lot when I was starting my job about how we had all this brain drain, but we kind of actually stole her from Harvard, a small university just south of us in Boston, small little place. But fortunately, we got her all the way here, and Dr. Ahmadi is an award-winning thoracic surgeon and just an absolute treasure and pleasure for us to work with, and so grateful to have her expertise on our team. And Dr. Ahmadi is going to present on new surgical approaches in the treatment of lung malignancies. And Nagar, over to you.
Awesome. Well, thank you very much, Dr. Law, for that kind introduction. And I'd like to thank the organizers for inviting me tonight. I'm very honored to be here and talk to you, everyone, about surgical approaches. We've heard great talks by some of my colleagues, and I'll be talking more specifically about how surgery has changed over the last few decades. So just to tell you about myself, as you heard, I'm one of the 4 thoracic surgeons. We do most of our operations at Michael Garron Hospital, but we're affiliated with Sunnybrook Hospital and see patients at the Odette Cancer Center, as well as North York General Hospital and the Royal Victoria Hospital in Barrie. Now, what do we do as thoracic surgeons? So we treat essentially organs within the chest cavity except the heart. So we treat any diseases of the airway. And one thing I have to say, some of the pictures I'm going to show later on some people might find them a bit graphic if there's pictures from the operating room. So if you're a little bit sensitive, feel free to minimize the video. So yes, what we treat would be diseases of the airway, diseases of the lung, the esophagus, the diaphragm, which is the muscle that helps us breathe, diseases of the lymph nodes, as you heard from Dr. Wong. So when patients have enlarged lymph nodes or to diagnose lung cancer, there are surgical procedures that usually involves a thoracic surgeon as well, and diseases of the pleura, which is the lining of the chest wall. But I would say probably about 60 to 70% of my practice being in clinic or in the operating room involves around treatment of lung cancer. Now, as you heard from Dr. Louis, lung cancer is the number 4th cause of cancer in Canada. And I'm just going to be showing similar sort of statistics, but more looking at trends and what's happened in the last 20 to 30 years in Canada. So when you look here, back in the 1980s, now lung cancer in men is shown in the dark blue figure, and then the lung cancer in women is shown in light blue. So what we've seen over the last 3-4 decades is lung cancer rates are decreasing. And that's in part due to, less people are smoking now compared to when they did in the 70s or the 60s. But interestingly, lung cancer in women has increased at least up to the 2000s, and then it's sort of plateaued. So when you look, there's certainly less lung cancer being diagnosed compared to breast cancer or prostate, but we still have quite a bit of work to do. Now, despite lung cancer not being the number 1 cancer in Canada, lung cancer, as you heard earlier, is the number 1 cause of cancer-related death. And again, just find these graphs interesting to look at over time. Even though we've done quite well with decreasing cancer death over time, when you look at the 80s compared to 2020, lung cancer in both men and women still remains the number 1 cause of cancer-related death. And you might ask, why is that? Is it because lung cancer is just more aggressive, or what is the reason behind it? And I'd like to highlight one of the at least contributor is the stage that lung cancer is diagnosed in. So this is another statistics from Canadian Cancer Society, and it shows the distribution of all lung cancers diagnosed in Canada within this 5-year period. And as you can see, about half of the patients that are diagnosed with lung cancer are actually diagnosed in stage 4. Now, when someone is diagnosed with any type of cancer, we tend to give them a stage based on the size of the tumor. Has it spread to the lymph nodes? Has it spread to other parts of the body? And unfortunately, a large portion of our patients are just diagnosed too late. There are some that are diagnosed with stage 1, even less with stage 2, and about 20% with stage 3. So how can we change that? Why are people diagnosed so late? And one thing that I really want to get across tonight is lung cancer screening saves lives. And sometimes I feel maybe lung cancer, as Dr. Louis mentioned, doesn't get the same attention as breast cancer or colon cancer, because we always do tend to attribute it to smoking. But regardless, we know that lung cancer screening saves lives. And again, I just want to highlight, if you or a family member or a friend who's in the ages of 55 to 74, and you're either a current smoker or a former smoker with about 30 pack year smoking history, pack year meaning you smoked more than a pack a day for 30, 40 years. And either you're still a smoker, or even if you quit and it's only been within the last 15 years, you should really talk to your primary care physician and ask them if you would be someone who would qualify to get a lung cancer screening CT scan. And patients who do qualify, they get a CT chest. And I can tell you, a lot of times, the early stage cancers that we are able to cure, either with surgery or radiation, are the ones that are just picked up because someone had a CT scan for another reason. So very important, if there's one point that I want everyone to take home, is very important to consider lung cancer screening. So going back to patients that do get diagnosed with lung cancer, so when we look at this figure, this is a little bit old, so probably now that we've started doing more lung cancer screening, hopefully we are able to diagnose people in earlier stages. But typically patients that end up with me and get a lung cancer operation are usually people with stage 1, people with stage 2, and a small portion of people with stage 3. Now, when it comes to lung cancer operation, it's not only the stage of the cancer, but also the shape of the lungs, the shape of the heart, in the sense that, is this person going to tolerate having a major lung operation? Any lung operation we do is really considered a major operation. And we do a number of other investigations, such as getting breathing tests, getting echocardiogram, to really decide if someone's hearts and lungs would tolerate having lung resection. So all in all, about 25% of everyone who's diagnosed with lung cancer ends up being a surgical candidate. Now, the type of surgery we do really depends on the type of tumor it is, as you heard from Dr. Louis. In the past, it used to be small cell, non-small cell, but now we have many subtypes. Depends on the location of the tumor. Is the tumor sort of out in the periphery of the lung, or is it more closer to the center? And depends on the size of it, because that will also dictate how much of the lung we need to remove. The most common lung surgery we do is what's called a lobectomy, where the lung on each side has lobes. So on the right side, there's 3 lobes. So there's the right upper, right middle, and right lower. And typically, if someone presents with a mass in their upper lobe, we remove the entire lobe. And the reason for that is not only we remove the tumor and the lung around it, but we also want to remove all of these lymph nodes that are around it, just so that, 1, we've removed any cancer within those lymph nodes, and 2, to really get an accurate assessment if the lymph nodes are involved and if someone has cancer in the lymph nodes. So how do we do lung operations? About probably 20, 30 years ago, everyone who needed a lung operation would get a big cut all the way from the back, right under the scapula, going all the way to the front. We used these rib retractors, where we try to spread the ribs apart because the chest wall is quite rigid. And sometimes, just spreading the ribs alone doesn't give us the adequate exposure, and we would have to either remove a part of rib or break the ribs to really get a good exposure. And the way we do the surgeries is usually the anesthesiologist put in a special type of breathing tube. And through that, we're able to collapse the side of the lungs that we're operating on, so that then we're able to move the lung around, dissect all the structures, and basically isolate the part of the lung we're removing, remove all the blood vessels, all the lymph nodes, and then remove that part of the lung. Now, what's changed over the years? Because surgery in lung cancer has certainly gone through significant change. So again, this is sort of the old exposure, we still use it sometimes, but I would say nowadays, probably 90 to 95% of our surgeries that we do are minimally invasive. And the term we use is video-assisted thoracoscopic surgery. And what it involves is putting in a camera through a small port, putting in instruments through, other small 1/2 inch incisions, and doing the surgery that way. We would have to make one of those incisions a little bit larger to actually remove the part of the lung that we remove, but we're still able to do all of the operation through the small incisions. And I'll be talking a little bit about the role of the robot, because as you heard, the robot's being used in the US for diagnostic purposes. The robot is currently being used in thoracic surgery for doing lobectomies, both in Canada and in the US. And the approach is similar. I'll show you some of the pictures later on. So this is how we do lung cancer surgery nowadays. So this is us in the operating room a few weeks ago, myself and my 2 residents. It was an all-women team. And we put in the camera through the side. So the patients, when they come for their surgery, they're on their side during the operation. The anesthesiologist is sitting just behind the curtains there. We put in a camera, our 2 instruments on the other side. We have the screens positioned on each side of the bed, and we're able to do the entire dissection through the small incisions in the camera. And then, as I said, we make one of those incisions a little bit bigger to remove the specimen. So this is how it would look like when we see the patients in clinic, usually 2-3 weeks later. So what is the difference between doing the video-assisted thoracoscopic or VAT surgery as opposed to open surgery? So you can obviously see, instead of having a big incision down here, we're having a few smaller incisions. And it's not so much, when it comes to lung surgery, it's not so much the size of the incision, but it's the fact that when we do the surgery through camera, we don't actually have to spread the ribs or break the ribs. And that's what's really made the difference in recovery, because when we don't do that, patients are able to take deep breaths much quicker. When they do that, they're able to clear their secretions. So they're less likely to get pneumonia or other complications. They have a much faster recovery. So generally, when patients come in for their VATS lung resections, they're in hospital usually 1 or 2 days. Often it's mostly 2 nights that they stay. And then when they go home, often they just go home on Tylenol and Advil. Sometimes they need maybe the occasional narcotic, but overall, it's really changed the practice of thoracic surgery, being able to do these surgeries minimally invasive. Now, what about the robot? So when we do the robotic lung resections, basically the way the robot works, and it's similar across all fields that use it, this is the robot basically that comes and gets docked at the patient's bedside. So once we position the patient, put in all our sterile drapes, we bring this robot and put it on the side. And there's always one surgeon at bedside who helps with changing the instruments. So this robot has these arms and they move. But the control for these arms is actually on the console, and it's usually at the sort of the side of the room. So the main surgeon who's operating and using these joysticks to move the arms of the robot is actually sitting at the side of the room and is controlling these arms through these joysticks that we hold. So we dock the robot on the side, and then we're able to move these arms sort of remotely. Now, what is the difference really between the video assisted and robotic assisted? I think the outcomes are fairly similar, but with the robotic assisted, we're probably able to get a better visualization of the camera, as opposed to, because if you imagine when we're doing it with video assisted, there's someone actually holding the video, versus when we do it with the robot, that's the machine that's holding the camera. So a little bit better, and the quality is a little bit better. And then when we do it video assisted, we have these instrument specific instruments that are designed to be used in video assisted surgery. And we do our dissections, whereas when we use the robot, the arms of the robot, it actually gives us it basically gives us 360-degree freedom to use the arms. So it provides a little bit more finer movements compared to the video assisted, but they're both very similar in their outcomes and in the post-operative recovery period, as well as the oncological outcomes. So our ability to remove the tumor in an oncologically feasible way. So in addition to the technique and the instruments and the way we do our operations, what's also changed is the type of lung surgery we do. Partly it does depend on the size of the tumor, but as I said, the most common type of lung surgery that most people get is a lobectomy, where we remove the lung around the tumor, as well as the windpipe that goes into that part and all the blood vessels. But more and more, through developing finer techniques to do the lung resections and research that has compared the different lung resections, more and more we're able to resect less lung resection, at the same time not compromising the blood vessels or the lymph node resection. And that's what's called, just the sort of the medical term for it is a segmentectomy. So what we do is we do the same dissection. We really have gotten really good at isolating only the blood vessels that go to that segment of the lobe. So when we do these operations, we don't remove the whole lobe, we actually just remove that part of the lung that has the tumor around it, but at the same time, making sure we get all the lymph nodes and the blood vessels that go to that. What it results in is less lung being removed, which always would help with improving respiratory outcomes post-operatively. And we're still, as I said, able to remove the lymph nodes. The real big advantage of being able to remove less lung is, as again, you heard from Dr. Louis, sometimes patients develop a second lung cancer, or they get treated or even cured for their first lung cancer and then develop a recurrence. And when we are able to use minimally invasive techniques and remove less lung, these patients get another chance at potential cure when they have a second tumor, either through another surgery or combining surgery with other therapies such as radiation. So just to summarize, again, I really want to get the point across that lung cancer screening saves lives, and I really want everyone to take this message home tonight and really consider lung cancer screening and discuss it with your family physician. And, just hope that I was able to highlight some of our newer minimally invasive techniques in lung resection that basically result in quicker recovery, less post-operative complications, and improved patient experience. And I'd like to thank everyone. And I just want to put a picture of our new building at Michael Garron Hospital that's almost finished, hoping to move in later this summer. We're going to move all our clinics, surgery clinics to the new building. So we're all very excited. And again, thank you for everyone for having me.
Amazing. Thank you so much. I really appreciate your talk and your enthusiasm, and certainly the screening message hits home. I mean, I have had two of my dearest and uncles that I've loved both pass away from advanced lung cancer, and you think, boy, why didn't we ever bring them to the doctor sooner? They smoked all their lives, So I appreciate that. Just for our audience, just let you know that this is the conclusion of our formal presentations. We're going to start collating our questions now. It's definitely not too late to submit a question if you want to do so still. And I'm going to ask our other presenters to turn on their cameras as part of the panel. And then I'll just try to throw a few out there. And Dr. Mata, I'm going to start with you actually, because you left us with such a compelling message, and we might as well keep going on that theme. And I thought this was a really interesting question, and I gave you a hint. I think it's relevant to me too. And the question was, what about screening for those of us who grew up with secondhand smoke in our house? And there's lots of variations of that. Maybe I'll start with your perspective there, Nagar.
Yeah, absolutely. You know, it is a great question, and we get asked these questions all the time. And it's not just the secondhand exposure. What about people who vape, or what about, you know, other forms of smoking? I think part of the answer would be probably there's a bit of a gap in our knowledge. And so far, the recommendations are for people who are cigarette smokers. But you know, anyone who is within that age category and is having any respiratory symptoms. So it's always important to remember what could be some of the symptoms. So if, you know, you have a cough that doesn't go away, you've seen a lung specialist, or if you start coughing up any blood, weight loss, those would be all symptoms to bring up with your primary care physician. But I'd say most of the guidelines still recommend that it's at least based on the studies we know, because if you imagine every time we do a CT scan and there is a spot that's found, then those patients would have to go through other testing. So when they look at the cost benefit of doing mass screening versus, you know, what's the benefit we get from it, so far, all we know is mostly for people with who are smokers or former smokers. Whether that will change in the future, we'll have to see, but any respiratory symptoms, again, those would be things to bring up for sure.
You're on mute, Dr. Law.
I love using my lips, but no, thank you. Yeah, that's very helpful, and certainly gives us something to think about. And, you know, I think it leads to another question that I think, you know, one of the audience members posed, but it's also something that I see, not as a lung surgeon, but sometimes when I do scans in preparation for my patients. And maybe I'll throw this one at you, Harvey, and see what you think. But, you know, what do we do with these small calcified or granulomas, sometimes they call them? And, you know, those of us who aren't lung experts like the three of you, we sometimes don't know what a granuloma even means. All we know is it's a lump. And, you know, and an evening like this can make us worry about that more. Any advice? Do granulomas turn into something? Do they need more follow-up? How should we approach those?
No, that's a good question. So we know that usually when calcium is present, it is usually generally a good marker, because calcium deposition it means that there's chronicity to it, meaning it's been there for a really long time. It takes time for that calcium to deposit. So I think it really depends on what that nodule looks like, the size, and is it entirely calcified or is it just partially calcified? I can tell you that if a nodule is completely calcified, then that is not something that we ever have to worry about, because the whole thing is just a calcium deposit. Those things are never really going to be a problem, and we know that. Now, we know that there are certain other types or patterns of calcification which may mean, it may not be cancerous right away, but it may mean that it could be a precancer, or it may be a scar that can become cancer. We used to use the term scar carcinomas to say, you know, that it started off as a scar, but slowly over time, parts of that nodule mutates or becomes cancer. So certainly really depends. I would say it's a case-by-case scenario, but generally speaking, calcium is a good thing. And if the whole thing is calcified, then it's not something that we worry about. And generally speaking, when we don't know, when it's just partially calcified, or there's a certain parameter we're looking at and we're saying, you know, could be, the general approach is we usually follow those, because unlike moles on your hands that you can just look and just take out, it's much harder to take out these nodules. You heard from Dr. Amadi that it's very hard to take them out. So we usually just follow these with repeat CT scans, which is the best way we can to follow these nodules when in doubt.
That's really helpful. Thank you. And reassuring too. So, you know, well, remember, calcium is good, not just for your bones, but for your scans. Okay. Nagar, you mentioned something in quick passing. We're going to throw it to Alex as well, which is this thing with vaping. It's interesting because I grew up in that time where we were just transitioning from, doctors smoking on TV to learning that it causes lung cancer. And then as I grew older into my teenage years was stop smoking, stop smoking. And so I grew up in a time where I saw cigarette packages right out in the open. Now it's behind counters. Now they have warnings behind them. And you sort of start, in a weird kind of way for my generation, you start forgetting about that. And then, my kids laugh at me because I asked if you can pick up smoked meat at some place called Tokyo Smokes. And they're like, Dad, you're so behind the time. And I thought it was some sort of Asian version of smoked meats, but I guess not. And I guess the question is, I don't even know how to word it, but what's the risk with, let's say, both vaping? You can pass it to another member, Alex, if you want, but like vaping and also obviously cannabis, smoking, etc. Like what should we start thinking about, or what would healthcare experts like yourselves start to tell people in terms of their perspective on those?
That's an excellent question, and certainly a very common question, both from a lay perspective as well as within health professional circles. And what I would submit is that it is an evolving research question. And what I mean by that is the immediate effects in terms of the risk of vaping. The information that we have is it does not seem to be as dangerous as cigarettes in terms of carcinogenic potential or developing lung cancer, but we really don't have the long-term follow-up or the long-term sort of looking into the future. If someone vaped for 10 years, what's going to happen 30 years from now of their risk of developing lung cancer? But there have been a number of groups worldwide that have tried to analyze the substances that are within e-cigarettes. And what they've noted is a few things. Number one is that on average, there appears to be less cancer-causing substances, but by nature of when it gets lit up as well as aerosolized, that's where sort of the risk happens of potentially becoming cancer-causing. And the second aspect isn't just in terms of cancer-related disease in the lung. Dr. Wong may be able to comment, but there are these sort of dramatic findings that we saw, pre-COVID that was kind of dominating the news of individuals who were very young and developing almost these oil deposits within their lungs and presenting to the ICU and having these very sort of dramatic presentations, and even in some situations, quite unfortunately, even being life-threatening. On the flip side, what's interesting and is a matter of public health debate is that there are jurisdictions in the world, for instance, the UK, that is, as part of a public health message, are actually encouraging the use of e-cigarettes as a way to quit smoking, what they call sort of risk reduction, in that the vaping can be sort of a substitution risk to cigarettes, in that it is a lower cancer risk and can be used as a tool to quit smoking. Now, of course, that is a proposal that is somewhat fraught with criticism on both sides, and that, yes, perhaps on the macro scale can result in decreased cancer incidence, but on a person-to-person scale, should we be trading one potential problem for another?
Yeah, thank you. Harvey, do you want to add to that, since Alex pointed out to you?
Yeah, no, I fully actually take a very similar stance to Dr. Louis. It's a common thing that I get asked all the time. And the party line I usually say is, we just don't have enough data to know for sure. You imagine, back in the early 1900s, everyone was smoking, and you had pictures of doctors smoking and saying, this brand is my favorite brand, please smoke because it'll make you feel better. It took years of data to convince people in the public and even the medical community that smoking was bad. And the vaping products are just so new that we don't have enough data to say definitively one way or another. As Dr. Louis mentioned, there are some immediate effects that we know that are very harmful. And we have some kind of more medium-term kind of data to show that it can cause increased sputum production. So you're coughing up more secretions, there's just more coughing, so it can reduce quality of life from that perspective. But in terms of long-term risk for cancer, I don't know that we have the exact data for that. So my usual approach, right or wrong, is I do look at it in a way of, we know for sure smoking is for sure bad. Vaping, we don't know for sure. So if someone had a really hard time quitting and they said, now I'm gone to vaping, I will say, well, it might be better. So I would take that over smoking. But the truth is, I do tell people, listen, our lungs were not made to really inhale anything other than air. So if you're inhaling anything else, you have to understand that that's not how we were made. So you just have to know that there might be data coming down years later that show that, you know what, there's a lot of harm from this, and we just don't know at this point.
That's really helpful. Thanks. Now, there's a couple of questions on this that I'm going to combine together because they're quite related, but it certainly goes to people who have never smoked and get cancer. There's this question on why do people know why the never smokers, particularly this person seems to think women, get lung cancer, and combine that with another question would say, how do we detect it in especially in a more elderly woman? So I think there must be some concern here from women about getting lung cancer when they were not the primary smokers. And maybe I'll start with you, Nagar. Like, do you have any advice on that? And any number one thoughts of how do you get cancer if you didn't smoke? And secondly, things to look for if you're a woman that thinks they're at lower risk, but actually does end up getting lung cancer.
Yeah, for sure. We certainly do see, I mean, in my day-to-day clinics, I definitely do see patients who never smoked. And one, it has to do sometimes certain types of lung cancers. For instance, there's a subtype of like neuroendocrine tumors or carcinoid tumors that we see it in non-smokers all the time. But also similar to how, women with the BRCA gene are more at higher risk of getting breast cancer, there are certain genetic mutations that now we're starting to know about that make you more prone to have lung cancer. And there are actually now a lot of targeted therapies that are specific for those genetic mutations. And we know a lot of times we see these in people who are never smokers or females, and certain even ethnicities are even those genetic mutations are more common. In terms of a screening, again, it sort of comes back to right now, these are the guidelines based on, this is sort of where we're going to capture most of the lung cancer is people who are smokers. So again, there's no real screening guidelines, but if you have a very strong family history of lung cancer, that is a risk factor for lung cancer, even if you weren't a primary smoker. But unfortunately, we haven't narrowed it down, just like how we have with, for instance, the BRCA gene for breast cancer. Hopefully, maybe in the future, that will be something that we will know more about.
Amazing. Well, I'm going to connect that over back to you, Harvey. So I think the message I got was, even if you think you're in a low risk group, be aware of symptoms, right, Nagar, and just make sure you seek help if you do it. And maybe, Harvey, how can the Ldap help somebody like that?
Yeah, I mean, just to answer that question directly first, I mean, any physicians can refer to our diagnostic assessment program. There's actually a multiple around the city. In fact, Michael Guerin has one that is very similar to ours, and we work very closely with theirs as well. But any physician who has any concern of their patients having cancer can refer, and we encourage people to refer if there's any concern that there is an X-ray or a CT scan that shows any sort of shadow that looks suspicious. Just refer, and we don't usually turn patients away. We will work them up, and if it ends up being not cancer, great. That's what I love. I love to give people good news, but you never can be too careful. So if there's any concern, please do refer. The other point I want to make is, there are, for sure, you want to watch out for symptoms, but the truth is most early cancers, the most common symptom is no symptom. And the reason for that is that the lungs do not have nerve endings that feel. So I tell people all the time when I do these procedures, these bronchoscopies, one thing I can reassure them is that there's generally no pain because there's no nerve endings there. So by the time you actually do have pain, and I get this comment all the time by patients, I never had pain, I never had symptoms, how can I have cancer? Well, the reason is because you actually can't feel your lungs. And so that's the whole purpose of screening. The screening is to screen people, and most people do not have symptoms. By the time they have symptoms, it's usually too late because it has spread to the bone to cause bone pain, or it's become very big and has invaded into a blood vessel. Now they're coughing blood. So I echo, my colleagues in that, if you fit in that range where you should be screened, regardless of symptoms, you should be screened.
Yeah, thank you. Very interesting. Just to change the tone a little bit, I don't even know how to answer this question, but Alex, I'm hoping I'm picking your brain here. But and maybe this is too early still, but the question was, has there been a drop in lung cancer after all of us have been masking for these last 2 years? Did that do anything? I'm actually worried that a lot of us went home and smoked quietly. But anyways, here we go. Alex, what do you think of that question?
That's a good question. And I would submit that the number of cases of lung cancer that we're detecting, and I don't think it's necessarily just lung cancer, I think it's cancer in general. The number that we're seeing in the last 2 years because of the pandemic is less. Now, what you want to attribute that to, there's lots of different theories, but I think the strongest reason is that it's not so much that the actual number of cancer cases is different in 2020 or 2021 or 2022. It's the fact that we're not seeing them as much by nature of individuals' reluctance to seek medical attention. And that's across the board, cancer or not. It can be more challenging to get in to see an office. Individuals may be less motivated because of social distancing, because of quarantine regulations and things like that. And I think that the take-home point that somewhat ties into the prior question of, well, I'm an individual who had no sort of usual risk factor for lung cancer, i.e. I'm not a smoker. What can I do to try to improve my odds by finding something earlier? And that is, even while many aspects of life have evolved, many aspects of healthcare have evolved, and us at the cancer program, and even province-wide across many disciplines, there is a try and push to try to see how we can complement the usual face-to-face office visit with virtual visits, more phone use, more Zoom use. I know we're probably all zoomed out, using all sorts of telehealth networks, and to try to not ignore what is clearly something that's troublesome and potentially increasing. And that's very, very common, that we're seeing it over and over again as health providers, where we have a situation where an individual feels that they should have done something sooner, but they're very worried about seeking that care. But as it relates to the specific question, the drop in lung cancer, I would say yes, in terms of the quote unquote rate, although I think the rate's probably the same. Is it because of masking? I'm not convinced that that's the reason, unless individuals who are masking are also by nature of wearing a mask, not smoking as much.
Yeah, that's right. Okay. I'm sure this whole pandemic will bring us some interesting data in the years ahead, I'm sure. And there's still lots to learn. And we're not even out of it yet, to be honest, don't forget. Nagar, back to you. So there was a lot of interest, obviously, in the surgeries that you did. And this is an interesting question. So I'm going to give it to you just the way it was written, but you can expand on it, because I think it's not the way I would normally think of a question, which is, what is the smallest size tumor that can be operated on? And I say that's interesting because, sometimes we think of alternatives for certain sizes, but anyways, how would you think of that?
Yeah, so certainly we could operate on any size. The only, I'd say, where size play a role is us being confident that we're removing lung cancer. First of all, and I always tell this to patients, if you were to scan 100 people in the room, most people would end up having spots in the lungs. And I always say spots in the lungs are like moles on the skin. A lot of times we don't know what they are. We need to keep an eye on them, monitor them, do repeat scans. Now, sometimes they look very obvious and that they're cancer, but a lot of times tiny spots like 4 millimeter, 5 millimeter, 6 millimeter, these are all small spots that most of them, majority of them are not going to turn into, are not cancers or are not going to become cancers. So for us to diagnose a spot accurately, either through a PET scan, which is just a sort of a special version of a CT scan, or to biopsy, usually that spot would have to be at least 8 millimeter or close to a centimeter. So I say typically the smallest size that we do remove realistically is probably about a centimeter or 8 millimeter. Now, sometimes people have spots that's a spread from another cancer, like colon cancer. And a lot of times these are 4 millimeter spots that we follow. And if they get bigger, we remove them. But I'd say often the tumors we remove, the smallest would be about a centimeter. And that's purely because then we can be very confident that we're doing the operation for the right reasons.
That's really interesting. So I thought I'd throw this next step back to Alex. Sometimes for us, when we're referring patients to you guys, we leave it to you for surgery versus radiation versus anything. Any comments from the Sabre side on that sort of size issue?
Yeah, no, I would agree with Dr. Ahmadi's suggestion that centimeter threshold relates to both feasibility of knowing that you're in the right spot, whether to remove something physically with a scalpel. And from a radiation perspective, when we're targeting at a normal cancer spot, we have to be accurate and precise and know reliably that we're in the right place. And generally 8 millimeters to a centimeter is the minimum threshold, not just to visualize, but when spots get to that size, they're more likely to be cancer. Whereas if you have something that's 3, 4, or 5 millimeters, and there's various types of calculators that you can put in that relate to demographics, size of the tumor, how it may be growing or not, whether or not there's color in it based on the PET scan, and that tells you how likely something is cancer or if it can actually be a benign finding or a non-cancer finding. So in some parts of the world, if you have a spot in the lung based on a scan, for instance, in Hawaii, the most likely reason is actually fungus exposure. And in some parts of Asia, it's actually tuberculosis as opposed to cancer. So all of those considerations that, you have an X-ray or a CAT scan and it says that there is a new spot, obviously the concern, is cancer, is the first thing that people would jump towards, but there are many different reasons for why you may have a spot that shows up on one scan and you scan again in 3 months' time and is actually gone, which would mean that it's not cancer.
Fascinating. Thank you. I know that one of the challenges now is the scans pick up everything. So it's all, and I think, Nagar, you said that earlier, you got to be careful sometimes how you read it, but that's why we have you guys, and and Harvey, the Ldap, and everybody else. You've got the expertise help to help all our community physicians and other physicians sort this through, But that doesn't take away from screening and be aware of your symptoms and ask for help when you need. A little detour again. I know this is not exactly what we talked about, but Harvey, when you were talking about the lining and the fluid, I think it certainly triggered a certain question. This one's one that seems probably very personal to this person, but the general theme is on something called mesothelioma, which I think is more the lining. And I guess the two-part questions was any advances in it that you know of that would encourage us, and I think the second thing is this person lost a family member from this, and the question was whether there was any risk because from being exposed, something like secondhand smoke. Is there something called secondhand asbestos? So I don't know if you can give any insight to that.
Yeah, I mean, unfortunately, mesothelioma is still one of those cancers that we have a lot of trouble with treating because we know that it doesn't respond very well to chemo or radiation. So it's a really devastating diagnosis to have. I mean, for the really fit person, sometimes surgery can be done, and I would gladly defer that to our thoracic surgery colleague here that's available to talk about that too. But it's really just in a very select few that have limited disease who are fit enough for this really, really invasive surgery to be able to have a chance for cure. Otherwise, we know that this particular disease tends to be slower in progression initially and eventually takes off at some point with not a lot of great treatments, unfortunately, for it. So that's unfortunately the unfortunate answer for the first part of the question. For the second part of the question, actually, interestingly, yes, there is a possibility for her. What you describe as secondhand asbestos, there are case reports of people who've worked in mines, asbestos mines, and bringing home asbestos fibers, and then having family members actually with asbestos-related lung disease. Now, that is not common. That is obviously not the predominant, reason why people get horrible asbestos-related lung conditions like mesothelioma. But we do know that, having those asbestos fiber particles brought home, people can inhale them, and family members and friends can inhale them and can have signs of asbestos-related lung conditions. But again, it's definitely not the predominantly the case. It's a very small minority that is the case, but it has been reported.
Okay, interesting. So just be careful and watch. Dr. Ahmadi, any comments on that, just as the surgeon?
Yeah, so, I completely agree with what Dr. Wong said. Unfortunately, when it comes to mesothelioma, it's also the nature of the type of cancer it is. One, it's usually diagnosed very late and can be quite aggressive. I think the only thing that I'd say is what's over the years, probably over the last 10 years, what's changed is we're better at diagnosing the specific subtype of the mesothelioma. So most centers actually only offer surgery now to a very specific subtype of mesothelioma as opposed to all mesotheliomas. And I think what's also really changed the treatment for mesothelioma is not really surgery, because the surgeries remain the same probably for the last 20, 30 years. It's the immunotherapy. And now we're able to offer that to patients with mesothelioma and hopefully improving their prognosis.
Okay, thanks. Okay, the next question is it's probably easy to answer, but Alex, maybe again, it's all about, I think there's so many things that have come from this pandemic, and it's really raised people's concerns. And this question relates to that. If we've had pneumonia several times over and over, does that increase our risk? And I can imagine a few people have been in and out of COVID, plus other things have felt that. Any thoughts or advice for them?
Yeah, that's a good question. I wouldn't say that the pneumonia itself is necessarily the reason for which having a potential increased risk of lung cancer, but individuals who have other lung conditions known as COPD and emphysema, if they're smokers or were previously heavy smokers, or let's say secondhand smokers, those individuals would be at somewhat higher risk of developing pneumonias. But it's kind of like the chicken and the egg of what is the sort of the start and the finish. So I think it's more so the fact that if an individual is a heavy smoker, and associated with that, they more often kind of reporting to the hospital or to their family doctor because they're getting more pneumonias, that could also be a reason that at some point they could be at risk of developing lung cancer. And to scrutinize the X-ray or the CAT scan that's done to help diagnose the pneumonia, maybe there's also an underlying lung cancer that's brewing.
That's really good advice. And it's not always the surface. Make sure you know yourself and your history better. Okay. There's one more question. It was a little bit off the wall from what I saw earlier, but I was a little bit concerned about it because I didn't want to leave this person without some advice. And Harvey, I'm going to go to you, sorry, but the question was, if you're having an asthma attack, does holding one's breath, is that an effective way to regain control? And I thought, goodness gracious, I hope this person doesn't have that many asthma attacks, but what advice would you give for that?
Yeah, no, generally speaking, I would say not. I mean, asthma is a inflammatory lung condition in the lung that can be triggered by various exposures. So common triggers are things like dust exposure, seasonal allergens, pet dander, things of those nature. And so when you're having an exacerbation or you're having an attack or an asthma reaction, it's because of that airway that is now swollen because of the inflammation. It causes narrowing of your airways, and people can get shorter breath because of that. So if this is a true asthma attack, then this individual would need some sort of medication to calm that inflammation. That's usually in the form of steroids and bronchodilators, so things that can open up the airways and things that can reduce inflammation. So that would be the general treatment for someone who has a true asthma attack. And I just realized that, you know, when you asked me that question about the mesothelioma, I didn't quite answer the family members and what they could potentially do. You know, if the concern is they had a loved one that died of mesothelioma, unfortunately, and that they may potentially had exposure. I mean, simple chest imaging will be able to kind of determine that. It does take years from the time of asbestos exposure to start developing lung conditions, usually even in decades. So if the exposure has been decades, usually chest imaging like a CT scan would be able to look for surrogate findings of whether or not there has been exposure that has caused any form of damage in the lungs. So that's looking for, we talked about calcification. So calcification along the lining of the lung is something that's commonly seen. Sometimes you can have thickening of that lining. So, you know, if there's any concern, you could start off with chest imaging and getting a CT scan. If that's clear, then the likelihood of, you know, and it's been decades, then the likelihood of there being any substantial risk is probably going to be very, very small, if negligible.
That's very, very, very helpful, Harvey. Thank you. Thank you for sharing that and for answering that question. I think you know, sometimes these little myths go around, and it's great to just have a chance to clarify them and also encourage people that, you know, again, the new imaging now will help diagnose things. We're coming to the conclusion tonight. I've really enjoyed this amazing conversation with our experts. I think that I'm very grateful to our audience for all the wonderful questions that they gave. I do want to encourage everybody. I think we started off on the right tone about how lung cancer sometimes gets a bad rap, but I think for the audience, you see this. This is just a sample of our amazing team that Dr. Louis leads here at the Odette, and they're working very, very hard to make sure that you have all the options. I think many of you will share how my mind was blowing tonight by all these different things that you have, from all the million ways you can get into the lung with a scope to Dr. Ahmadi using a joystick and removing your lung cancer, and Dr. Louis having a lightsaber for the Star Wars fans, I should say. But the point was, it's amazing how hard this team is working against one of the worst cancers. And I think Dr. Ahmadi reminded us, still one of the worst cancers, but they are fighting so hard. And I think one message I got was, don't be afraid of your history or symptoms. Go get some help. There's lung screening programs. There's the Ldap that can help your family doctor, and a whole host team here that is out to help you fight any possibility or sign of lung cancer in the years ahead. So please reach out. Please let our team help you. Again, thank you to our speakers this evening for all their precious time, spending time not only preparing and giving these amazing talks, but for engaging in the question and answer period. I have just a few more points before we wrap up this evening. So first off, please take a moment to fill out our electronic evaluation form. We definitely use that to help develop and plan our future talks with our community to make sure that we're presenting you relevant and good topics. You can definitely please add your name to our mailing list for future talks. And you can find us on the sunnybrook.ca website under speaker series. And you can definitely also look there for all of the future talks coming up. Aside from our wonderful speakers, also thank you to Tom Flynn from our board for providing our introductions. And also you can see how important these talks are are for all of us that the chair of our board of directors is here just to get our evening kicked off. So thank you again, Tom. Thank you very much. Big thanks to everyone now for joining us for this discussion. Again, check the future topics. Please take care, stay safe, and just breathe, everybody. Have a great spring. Okay, have a wonderful evening to everybody. Go Raptors.